Hi there, and welcome to this CM Learning Network Take a Listen podcast, a series featuring conversations with national thought leaders about trends in healthcare that affect case managers. I'm your host, Keri Boyce, Vice President of Marketing and Communications with Health to Resources. And on behalf of the Commission for Case Manager Certification, thank you for joining us. Today's episode is the continuation of a conversation featuring Dr. M.A.I.D Buchbinder around a sensitive topic, medical aid in dying. Dr. Buchbinder is a professor of social medicine and adjunct professor of anthropology at UNC Chapel Hill. She's the author of Scripting Death, a book on assisted dying that chronicles 2 years of ethnographic research documenting the implementation of Vermont's Patient Choice and Control at End of Life Act. She's also a medical anthropologist with broad interests in cultures of health, illness, and medicine in the United States. The Commission recently released a CM Learning Network webinar with Dr. Buchbinder titled Medically Assisted Dying in the United States, an Anthropological Perspective. This podcast is a continuation of our conversation with Dr. Buchbinder following her CM Learning Network presentation, which bridged the gap between the academic understanding of assisted dying and the real-world scenarios case managers face every day. We highly encourage you to watch her full presentation, which can be found at ccmcertification.org. And with that, here's the conversation I had the privilege of having with M.A.I.D following her presentation. I'm curious, what are the alternatives in jurisdictions where medical aid in dying is not available?
Sure. So I mentioned palliative sedation when I was speaking about a patient whom lost consciousness before she could consume all of the medication, and they had to kind of shift gears. So that is an option that is legal across the United States, and that simply means that a patient will be sedated continuously until they die. And so it doesn't necessarily cause death, but it removes suffering by keeping them sedated for that interval. It does require care by a physician that is trained with that expertise, whether it's a palliative care physician, typically, or a hospice physician. Another option that has received a lot of attention in sort of in the wake of legalization movements for medical aid in dying is voluntary stopping of eating and drinking. And this is, it's sometimes done under supervision of a physician, but it doesn't have to be. Someone can decide at any point that they're simply going to stop eating and drinking, and they can also change their mind at any point, which is what's kind of nice about it. So that I think is an option as well. And there are a lot of resources out there for people that might be interested in learning more about that.
Yeah. So how should case managers facilitate open and empathetic conversations about medical aid in dying with their elderly clients?
Sure. I think one thing that I heard again and again from physicians and other healthcare workers in this study is that a request for medical aid in dying is only a starting point, and it's usually not the end point of discussion, because most patients that bring this up are not going to end up getting it. And so even if this is coming up in a state where it's not legal, I think it can provide a really nice opening to sort of inquire more, dig deeper, find out, well, what's making you ask about that? What's on your mind? What are sort of your most bothersome symptoms? Often those are symptoms that can be addressed through something else. One physician that I interviewed talked about a patient with I believe it was a really severe form of multiple sclerosis. And she was basically saying to her doctor, kill me now, put me out of my misery. And it turned out that the thing that was bothering her most was constipation. and that was something that they could handle. So I think it's really important to say, well, what makes you bring this up? And I think it can open up a conversation onto other kinds of concerns. And then, in addition to kind of thinking about symptoms, I think particularly with elderly clients that case managers might be working with, this might be a good opportunity to just ask about how they imagine the end of their life, what they might want their death to look like if they have the opportunity to exert any control, what they might want their funeral to look like, right? Because what happens after death is something that we can plan for, in some ways more readily than the death itself. And so that might be part of it too, finding out about funeral preferences and that sort of thing. So I think that there's a really great opportunity for case managers to kind of dig a little bit deeper and find out what's going on behind some of these requests and what's motivating people and what are they scared of.
Getting to the root of that. Yeah. So this is a little bit on a personal note, but what has it been like for you to conduct this research and to be faced with all of this suffering?
Yes. One response that I often get after sharing this work is, this must have been so difficult for you, that this must have been so sad. And there maybe is a little bit of that. It's certainly sad to sit with people and listen to these stories. But I felt like it was an incredible gift for me as a fairly young person. I was in my late 30s when I was doing this research. And for me to just kind of be able to bear witness to the stories of death and suffering and end of life care really opened my eyes a lot. It made me more comfortable with death as a topic of conversation. It's not a topic that our society feels very comfortable with. And I think that it was a gift for me to kind of gain comfort in that area and to just listen. And so for me, the research really was life-changing in a lot of ways, to just even start imagining, what I might want in this position, and how I might be able to support family members thinking about these decisions. And so I found it in some ways really beautiful to be able to listen to people's stories of their loved ones' deaths and to be able to carry those stories. And it's a responsibility that I take very seriously as kind of a good steward of those stories, making sure that they're put to good uses and not being exploited in the way that the research is presented.
I love that, being a good steward of their stories. That's such a poetic way to put that. So what are your personal attitudes about medical aid in dying, and have they changed, since you started the research till now?
Right. Yes, they've changed. It not dramatically, but I think what happened when I went into the research, I was pretty naive about medical aid in dying in general. I came to the research not with a strong interest in end of life per se, but I had previously done work on abortion law and wanted to look at another area where law and medicine collide, and felt like end of life would be a good area to explore those interests. And so I just went in kind of sort of naively feeling like the liberal progressive position on medical aid in dying would be to support it, and kind of adopted that position when I was starting out. Felt like, patients' rights are something that I care about. And I think that I had those views challenged somewhat when I first started the research. And in my first summer, I interviewed a lot of activists who had who were on the opponent side. And I really saw the logic of their views and found their arguments pretty persuasive, and thinking about how a lot of what is motivating people toward medical aid in dying is kind of a fear of dependency, a fear of loss of control, the lack of familiarity with death. So one of the opponents that I interviewed talked about how she had been around death a lot as a child and felt really comfortable with it as a result, but many Americans are not. It's shielded. And so this just got me thinking about, well, I think it's actually a little bit more complicated than I was thinking. And then once I started interviewing some of the physicians, and some of the physicians who consider themselves pro-choice and supportive of patient choice and patient rights, but weren't convinced that they could prescribe life-ending medication and play that role. And, you know, we can talk about my life, my body, my choice, but someone has to write that prescription and be involved. And so I felt like the advocacy discourses were really flattening what I thought was a really actually quite a complex set of issues. So where I ended up, I think, is still in favor of medical aid in dying after kind of learning more and complicating my views and further fleshing them out. But I also think that if we want to make the end of life better for more Americans, this is not the way to do it. You know, I feel very strongly that this is an option that is going to be available to such a small number of people. And I think one of the hospice administrators that I interviewed talked about how it steals time from other issues. Medical aid in dying steals time from other issues because it takes a lot of public attention, and there are other things that we can do that might be less glamorous, but that would have a bigger impact on more people. And I think she's really right about that. I think it does steal time. And so while I'm supportive of it and think that it can be a wonderful option for certain patients, I'm also a little bit wary of this stealing time aspect of it.
And I think it's really interesting how you really, from the research, from you interviewing these physicians, it's not black and white. You're not necessarily on one side or the other. You can support a patient even if you would not write the prescription, you know, and I think that's just a beautiful in-between area of supporting a client, supporting a patient and their wishes, as well as honoring your own moral compass, if that's the direction you want to go.
Absolutely. Can I say one more thing about that? Because I think that what I saw happening is that people's views evolve in the context of a relationship. And so when you ask them in the abstract, what are your views on this? If you've never been involved in it, you might have one response. But then when it's coming up in the context of an ongoing relationship, you may have a very different response that changes over time. And I know that those relationships are really so crucial to case management work, that it's all about that relationship. And so you have to kind of think about it in the context of the relationship.
Absolutely. That's incredibly important for our case managers. What's next on the horizon for medical aid in dying in the US, and how do you expect these laws to change?
Good question. So one thing that we're starting to see, most of the original laws had residency requirements, so they were only available to individuals that could prove they had been a resident for 6 months of the state in which it was offered. And several states have recently voted to loosen those residency requirements. There have also been some movement to allow advanced practice practitioners to prescribe in addition to physicians. I think those are kind of where we're seeing the key changes, maybe reducing some of the waiting periods. I think there's a lot of interest I should say, a lot of interest among some stakeholders in relaxing the self-administration requirement and making this more accessible to people with certain disabilities. I don't see that happening anytime soon. I think that there's a sort of a sharp line for a lot of folks who think you have to administer it yourself to make sure that there's not going to be abuse. So that's one that I don't see budging. The other one that I think receives a lot of attention and debate, but that I don't see moving is patients with dementia, because the competency issue becomes really problematic. By the time you are expected to die within 6 months of dementia, you're not going to be competent anymore. So that's a real quandary, but I don't know if I see the 6-month requirement going anywhere anytime soon.
Mara, thank you so much for this session. This has been so informative, and I think this is going to be very beneficial for our case managers. Thank you for listening to today's episode of the Take a Listen podcast series, a podcast featuring conversations with national thought leaders about trends in healthcare that affect case managers. If you would like to learn more about today's topic, we offer an expanded webinar featuring Dr. Buchbinder in our CM Learning Network. You can find this webinar along with many other valuable resources at ccmcertification.org. On behalf of CCMC, thank you for your ongoing support and interest in the Commission.